I think it's probably of great importance that I talk to you guys about Ehlers Danlos syndrome and Tarlov Cyst disease, as well as connective tissue disorders in general. I suffer from Ehlers Danlos syndrome. It is the systemic cause of my numerous Tarlov cysts. And if you have numerous cysts and you don't have a clear event, trauma, or medical procedure to tie them to, and you show some of the symptoms that go along with connective tissue disorders, then it's my opinion that it is incredibly valuable for you to be fully evaluated as to if you have a connective tissue disorder or not. Just because of all of the extra focus, care, and attention that needs to be paid to the co-conditions that go along with it, as well as extra focus and energy on CSF leaks and the like due to fragile tissues. Ehlers Danlos syndrome is a genetic mutation of the collagen building blocks in our bodies. You are born with it. It's not something you develop. However, it is incredibly common for us to not show true symptoms of it until late 20s, early 30s or so. It does occur in children, especially when you're a parent that's been diagnosed with Ehlers Danlos syndrome. You pick up on the signs fairly quickly, but the symptoms that go along with Ehlers Danlos syndrome are so non-specific and general problems that unless you're approaching it from a point of view of where you're thinking about fragile tissues and the like, they don't really all fit together and make sense, because each one of the symptoms on their own are incredibly common everyday things that most of us have many of, but it's vastly different when you approach it from the true base of what is going on. I will say that the path to diagnosis for Ehlers Danlos syndrome can be just as frustrating and challenging as Tarlov Cyst disease. I fought with my rheumatologist for 9 months to be referred to a geneticist to get my full formal evaluation. And he was very much of the attitude of, I don't understand why you are pressing this so much, because I can't do anything about it. It's not like I can give you a pill that's going to help. I can't do anything about it. But, I told him, and just as I'll repeat here, that's not the issue. The issue is that if I have Ehlers Danlos syndrome, there are a number of things that I need to be looking out for myself, and I need to be evaluated and monitored for in my health, because there are numerous conditions that go along with Ehlers Danlos syndrome, and some of them can be quite problematic, and if not handled correctly can produce devastating consequences. So first, let's talk about the symptoms, as really they go across the whole spectrum. Most of us have the hypermobility type. I'm not sure why, but that's what we commonly present with. And so, of course, just by the name alone, we're going to have hypermobile joints, double jointedness. But anything and everything assorted with weak tissues, valves, sphincters, anything where a laxness to that ligament or tendon with joints and so on is directly related to the collagen problem. And so you're talking about acid reflux, because that's the sphincter being lax in your esophagus, letting the acid come back up into the esophagus. A history of any type of aneurysms, whether it be organs or brain aneurysms, that kind of stuff. Cysts like Ganglion Cyst, Baker's Cyst, synovial cysts. Those are cysts that are a result of a tear in a muscle sheath or a ligament sheath and fluid leaking from one place to another that it shouldn't be. Easy bruising, slow wound healing, and very strange scars called cigarette paper scars. They're very distinct, and it's best to just do a Google images search. I would show you mine, but all of mine are on my belly, and I'm not going to subject anybody to looking at my belly. Flat feet. Let's see. Hypermobility of the joints, of course, and that usually results in joint subluxations and dislocations. Subluxations are a bit different in that the joint almost dislocates but doesn't quite. I suffer from subluxing on a few of my joints, but I'm incredibly blessed to not have a lot of the subluxing and dislocations. Skin that tears easily, velvety smooth, stretchy. You'll see a lot of people pull up their skin as one of the signs. And another thing is like this kind of, I see this a lot, which I'm not quite sure. I guess that's a double jointed move. Prolapses, like uterine and rectal prolapses. I have a rectocele. For some reason we look younger, and I'll never understand that, because we always get told that women need collagen for, you know, your wrinkles and stuff. But if you actually look at my skin, I'm 42 years old, and I don't really have any wrinkles, and it really doesn't become apparent to me until like I have a class reunion or something and I see my, you know, counterparts and how they look. And, you know, truly part of it's probably that I don't have any kids, because, you know, I've made that comment before. I think kids probably do add a bit of stress aging to the face, but it's very common for us to look, you know, 10 years younger than we actually are. A lot of joint pain and laxness of the ligaments and stuff like that. Dr. Tennant did a full presentation on Ehlers Danlos syndrome and how much pain it truly causes, and he's classified it as one of the most severe pain disorders that there is. And, you know, I truly believe that. The joint pain that I experience with my neck and the joints that do sublux on a semi-frequent basis is pretty much unbearable at times. It can be very painful. But basically, your path to diagnosis usually is first seeing a rheumatologist, and if they are not comfortable making the diagnosis, because the diagnosis is really a basically set of clinical findings and physical traits that they look for, and in the hypermobility type they use two tools called the Baton and the Brighton. So you have the Baton scoring, which is actually hypermobility scoring for joints, and you have the Brighton criteria, which is just different criteria that you need to meet to qualify. And basically a score, sorry for the cracks, a score of 5 out of 9 points on the hypermobility Baton score signals joint hypermobility. Now that does go across the spectrum of joint hypermobility disorder and Ehlers Danlos, but the Baton score is used in the Brighton criteria for making the diagnosis. And, you know, you basically get points for each, if you can, you know, do the different things. On most joints, you're looking at greater than a 10% past 90 degrees angle on your knees, fingers, elbows, and it's important to note that as we age, our flexibility does decrease. So especially like placing the palms on flat on the floor, well, I could do that for years until I started having back problems, and then it just wasn't possible anymore. So that still counted against my score because I was previously able to perform it, but I just can't now with my physical limitations. And it's important to note that when you go to the geneticist, the types of genetic testing that they perform, the genetic mapping for the hypermobility type Ehlers Danlos is only about 60%. So only 60% of us will show the mutation. And you do not need to show the mutation to be formally diagnosed with Ehlers Danlos syndrome. In fact, my paperwork clearly states that even though I do not show the mutation for hypermobility EDS, my diagnosis still stands. Now on vascular type EDS, that is fully mapped. It is a foolproof test, and so you don't have to worry about that, not getting caught. But vascular type EDS presents very differently than hypermobility in that people with vascular type EDS have eerily translucent skin. I mean, seriously see-through skin. I can map my veins throughout pretty much my entire body, but I don't have vascular type. I mean, you just need to look at images of people with vascular type because their skin is just completely transparent. And then there's also some facial features that go along with it. There's also Marfans, which Marfans is not an EDS classification. It's a stand on its own kind of thing. But Marfans is another one where it's got a lot of usually very clear physical appearance traits. Like most people with Marfans have extremely long and thin long bones in their legs and their arms, and there's a lot of facial features that go along with it, but I was always convinced that I could easily spot a Marfans patient, and then I found out one day that a guy that I worked with who was 6'3", he had Marfans, and I would have never guessed it in a million years, and it actually ended up taking his life. He actually suffered a complete aortic dissection, which is one of the most common things that happens with Marfans patients, because basically the vascular system of a Marfans patient is undersized for their bodies, and so that's one of the things that will happen. And I'm pretty sure that that's what happened with John Ritter. If anyone remembers John Ritter, he either had vascular EDS or Marfans. I don't think he had Marfans. I think it was vascular EDS. Sorry, I misspoke. But basically, the most important thing about getting diagnosed is so that you can be monitored for the co-conditions that go along with it, and those things checked and you're on top of, because the things that go along with Ehlers Danlos syndrome, and I'm going to say these in list of occurrence really as far as frequency, are POTS, which is Postural Tachycardia syndrome, and that is that basically when you get up from a seated or laying down position, your heart rate will increase. The criteria is greater than 30 beats per minute if you're over 19 years of age over a 10-minute period. A lot of people have blood pressure fluctuations, especially the blood pressure dropping, and almost to the point of causing you to faint and faint in some cases. But the blood pressure fluctuation is not always a symptom. the heart rate is the criteria that is looked at for that diagnosis. Gastroparesis, which is basically a paralyzing of the stomach to where it doesn't empty correctly. Chronic fatigue, mast cell, and pardon me, I'm going to try my best to say this, dysautonomia. And basically that is, I find that incredibly confusing because it in itself is an overall name for disorders of the autonomic nervous system, and so things fall underneath it. It's not a condition on its own, it's a set of conditions that fall underneath it, if that makes any sense. So, you know, the things that fall underneath it are POTS, complex regional pain syndrome, syncope or fainting, and the symptoms are, you know, excessive fatigue, thirst, sweating, blood pressure fluctuations, dizziness and lightheadedness, neurogenic bladder and bowels, IBS, heat intolerance. There's just a lot of things that go along with it. Another thing that really needs to be done and monitored is your aortic arch needs to be ultrasounded for any aneurysm or weakness there. So you really need to enlist a cardiologist if you have EDS. Sleep apnea is another thing that most commonly happens. But basically, a geneticist usually will basically come up with an inventory of all of these symptoms and findings and use both the Baton score and the Brighton criteria to come to your diagnosis. And as I said, this can be almost as frustrating and long as the journey to get diagnosed with Tarlov Cyst disease, but it's incredibly important so that you have the correct focus on the co-conditions that commonly go along with it, and that if you are having surgery, that your surgeon is fully aware of your EDS so that extra care and focus can be made to, you know, the fact that your dura and your tissues are going to be more fragile than a normal patient, and extra monitoring has to be done for cerebral spinal fluid leaks. I myself developed a spontaneous leak about 2.5 weeks after my original Tarlov Cyst disease surgery. It was not an area that had been worked on, but there was some indication that maybe a cyst had kind of been touching that area and weakened it a little bit. But, you know, my leak happened completely on its own. And a lot of EDS patients can actually have slow CSF leaks. There's just a number of things that can happen. I've really tried to present this from a semi, not a high level. You know, if we were talking 500 feet, I've tried to present it from like a 50-foot level. So I know that I've left out probably a ton of things, and I really would appreciate any questions you have, or if there are things that you need me to elaborate on, I can make separate videos for that. I really appreciate you leaving feedback and comments about those types of things so that I can get those things done and meet the needs of what you guys want to see and want to hear about. So please, if you have any feedback or questions or comments about that type of thing, don't hesitate to leave them for me. I greatly appreciate them. I hope this has been informative, and I hope that it's not worn you out. It's kind of a long video. I've tried to make it as short as possible, but this is a very long and difficult subject. But thank you for hanging in till the end, and stay tuned for more videos, and thank you, and have a blessed day.